start the program. Sir, start
Okay.
sir.
Okay, sir. Okay. Go ahead.
Good evening, everybody. Today we have got a public health program. So on the occasion of World Health Day, we have to put a certain different and important topic on the occasion of World Health Day. That is the topic is CA breast. We have taken one particular cancer, that is a CA breast, so that we can have a good elaboration and also discussion, and we will have a conclusion based upon the one topic that is called as CA breast. As you know, it is one of the most prevalent cancer in the world. 8 million people are suffering and they are alive with the CA breast. And it is second most common cancer after the skin cancer in the woman. Any patient comes with a lump in the breast or discharge from the nipple, they are having a suspicion, they are having a different warning symptoms. So we want to detect early. How best we can detect early, that's the carcinoma breast, so curability is very much high. Let us have a discussion and we will have a conclusion based upon we have got two experts. One is Dr. Irappa Madhavavi from the Bagalkot. He is a medical oncologist. Second one is Dr. Puvamma from the Bangalore. She is a oncosurgeon and she is also a fellowship in the breast cancer surgery. So let us have a discussion among this and important topic. Among us, we have got a important the moderator of this time, Dr. Tejaswini Vallabha, madam. She is a senior surgeon as well as professor of the BLD Medical College, Bijapur, in the Department of Surgery. Madam is, we are all students of the madam, Dr. Tejaswini Vallabha, madam, and I have also completed my MS under the examinership of madam. And with this, many, even Dr. Puvamma, madam is also the student of Dr. Tejaswini Vallabha, madam. So with this introduction, let us start. And I, on the behalf of IMA KSP Public Health Program, I heartily welcome today's our speaker, Dr. Puvamma madam, as well as Dr. Madhvavi sir, and also today's the moderator Tejaswini Vallabha madam for this today's important the topic is the CA breast. And I heartily welcome IIKSP the President Dr. Shivkumar Lakul sir for joining the program, as well as sir has showed the interest that you do the program under the World Health Day. And also I welcome Dr. Karunakar sir. Sir is always busy at this time. Sir is arriving. Last time also I called sir, I disturbed. So I welcome Dr. Karunakar sir for joining this program. And also I welcome the Padma Prakash madam and the Veena madam and all other IMA members and everybody. I welcome for the today's the public program. Let's start the program with the prayer. Sir. Sir.
Yeah. Thank you so much. Thank you, Dr. Suresh. Good evening, everybody. Good evening, President sir, and every one of us. I think he has rightly pointed out one of the important cancer that need to be looked at as the wild publicity has to be given for early recognition and treatment is breast cancer, actually. We also observed this year, possibly we have more discussion on the breast cancer in all the platforms, including AMS, public health, and also in the women's wing activities also. I'm sure even in Bangalore also, Bangalore branch also conducted a few activities on this already. So possibly we have been able to educate most of the people through that. And one of the important thing as a public health platform, we need to reach out to more public. Actually, maybe the committee can explore the pros and cons of sharing the link to the public actually. So are we going to do that? Are we going to restrict to training only medical professionals? That has to be looked at. Because as a public health platform, reaching out to more people will benefit more from the expert speakers and the moderates. That's one of the observation I could suggest at this point of time. I'm sure our members are going to enjoy today's session also actually. So with this, I would like to take the opportunity as a Secretary of IMA KSB to propose the IMA prayer. I'm going to start it now. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವರು ನಾವಾಗಲಿ. Jai Hind, IMA Churaivagali. Thank you so much. It's back to you, Dr. Suresh and the team. Thank you so much.
Thank you, sir. Thank you very much, sir. Now coming to the next, Dr. Shivkumar Lakro, sir, President speech about the today's program.
Okay. So, can you hear me, Suresh?
Yes, sir. Yes, sir.
Good evening to all. IMA KSB and Public Health Subcommittee conducted many very good programs. Among them, today's World Health, on account of World Health Day,
Sir.
They are conducting the very good topic like CA of the breast. Already Suresh Kagalkar and also our secretary enlightened about the importance of this topic, and our secretary Karnakaran and also the convener of this public health Suresh Kagalkar, and also all the members of the IMA KSB, Madam Veena Madam, Padma Prakash Madam, and I think Rajeshri Anugulam Madam also is there, and all the esteemed members of IMA KSB. Today I have got a very good topic like medical management of the CA breast. The good speaker, Dr. Irappa Madan Bhavi, who is a consultant, medical consultant and pediatric oncologist and hematologist from Bawalkot. And also the second topic is surgery management of CA breast. We have got a renowned speaker like Pooma CV, and also she is a senior consultant and director of the breast of oncologist and a plastic surgeon from Bangalore. And we have got a moderator, Dr. Tejaswini Vallabha, the professor and senior surgeon of BLD Bijapur. So we have an opportunity and fortunate to have all these members. They will speak on the breast medical management, surgical management, and also moderator, Dr. Tejaswini Madam. And I wish you all the best. And once again, I welcome you all. And I will hand over the mic to Dr. Suresh Kagalkar for the further proceedings. Thank you. Thank you.
Thank you very much, sir, for your enlightening the few words about the program, sir. And next session is that we'll have one brief introduction about our chairperson, Dr. Tejaswini Vallabha Madam, by Dr. Padma Prakash Madam. Padma Prakash Madam.
Yes, sir. Good evening, everyone. On behalf of IMA KSB, once again, I welcome Dr. Shivkumar Lakkolse, the President, Dr. Karnakara, the Secretary, the speakers, Dr. Pooma, Dr. Irappa, and the moderator, Dr. Tejaswini. I'm really privileged to introduce our moderator, Dr. Tejaswini Vallabha. She's a professor and senior surgeon, Shri BLD Medical College, Vijaypur. She completed her MBBS from Gulbarga Medical College, MRMC Gulbarga, MS General Surgery from WIMS Ballari. Later, she joined BLDA's BM Patil Medical College and Research Center as a lecturer in the Department of Surgery, and later she was promoted as a professor. She was the first controller of BLDE deemed to be university in 2008. Later took over as the head of the Department Surgery and HOD Medical Education 2010 and 2019 till then. She's been trained in gastrointestinal endoscopy and laparoscopic surgeries at AIIMS Delhi, the prestigious Medical College of India. She has performed more than 7,000 upper GI endoscopic surgeries as well as colonoscopies. She was among the panel of experts in surgery for UPSC and the Government of India and Karnataka Public Service Commission. I'm really privileged and take this opportunity to welcome you, Madam. Thank you.
Thank you very much, Madam. Now, next we will have an introduction about the today's the speaker, Dr. Irappa Madbhavi, sir, by me. Dr. Irappa Madbhavi, sir. Sir is a medical oncologist working in the Bagalkot in the Kerudi Hospital for more than 10 years. Sir is a resident of Bijapur. He has completed MBBS from the 2008 in the Rajiv Gandhi University of Health Science. He has in 2016 in Gujarat University, and he has worked in various places. Initially, he was working in the assistant professor in the JNFC Medical College, Belgaum, and he has worked in the Ninjappa Medical College, Joka. And also he was a consultant oncologist and hematologist in the Shimoga Hospital, Shimoga. And he was a consultant, right now he is a consultant oncologist and hematologist from the 2016 till today, working in the Kerudi Hospital, Bagalkot. Sir has got many experience. He has got experience in the comprehensive management of many solid tumors, especially in the adult and pediatric and hematological disorders. And also he has got experience in the stem cell transplant. He is well versed with the latest chemotherapy, especially in the CA breast and the CA lung and lymphoma. He has got many reference as a neoadjuvant therapy and adjuvant chemotherapy with the different surgeon. And he has got experience as a multimodal treatment with the different specialists. And he has got experience in the daycare procedures, and he has done various daycare procedure also. And he has got various publication, more than 10 publication he has got, and more than 15 articles in his name. And he has worked in his name as a review article and many case reports with this. With this brief introduction, I'll complete the Dr. Irappa Madhavi sir, and I welcome.
Thank you, sir.
Thank you, sir. Thank you. Madam,
Thank you, sir.
Padma madam, please give brief introduction about the madam. Poma madam. Padma madam.
Yes, I'm here, sir. Dr. Poma, she's a senior consultant and director of breast oncoplastic surgery, Sidecare Hospitals, Bengaluru. She graduated her MBBS from Kasturba Medical College, Mangalore, and Master of Surgery from BM Patil Medical College, Bijapur. She has done a fellowship in breast diseases and cancer from Rajiv Gandhi University of Health Sciences. She has done an international fellowship in oncoplastic reconstructive and aesthetic breast from the Germany. She's got vast experience in oncology field by practicing at Majumdar Medical Center, Manipal Hospitals, Narayana Hridayalaya Multi-Speciality Hospital, Bangalore. And she is very excellent in academics, and she's got a lot of paper presentations at the state and national level. Adding feather to the cap, she has got a lot of publications and teaching experience, and she has given a lot of health talks and telemedicine talks to African continent. Professional and affiliations, she has got she's a member of Breast Surgery India, International Society of Surgery, Breast Association of India. So hereby, with a brief introduction, I welcome to the talk Dr. Poma. Thank you so much.
Thank you, madam.
Dr. Suresh, sir? Dr. Suresh, sir?
Very medical students.
Poma madam, you coordinate Madi madam. You start.
I think Dr. Irappa sir can go ahead with the talk.
Yeah.
Thank you, sir.
Yeah, please.
Connection.
I will share the video.
Hello.
Poma,
Yeah.
Sir,
Poma
go ahead,
madam.
sir.
Before that,
Dr. Irap, sir.
yeah. Before that, Dr. Tejaswari madam,
Yes, sir.
I will hand over to you, madam. Please go ahead with the program, madam, and give brief details about the program, and give brief introduction about the program, as well as we have a control about different questions, and many questions will be in the chat.
Okay, sir. I think right now both of them are ready with their presentations, I think, right, sir? My request would be to focus mainly on the general broad guidelines and also the stage-wise anything specific which you would like to communicate rather than extensive detailed coverage, because basically
medical
it is for
students,
general
sir.
surgeons and also non-surgeons who are interested in knowing the details of the CA breast. So I think the first speaker is Dr. Madhavi. Sir, can you go ahead with your presentation?
Yes, ma'am. Thank you. I will share the screen now.
Please share your slides.
Good evening, ma'am. I'm very thankful to KSB, Dr. Kagalkar sir, and Dr. Veena madam, Dr. Padma madam, and Dr. Tejashwini Madam and Dr. Puvama Ma'am. I will be presenting on medical management of carcinoma of breast. I will be presenting on the following headings like epidemiology, adjuvant treatment, neoadjuvant treatment, and palliative treatment. Breast cancer is the commonest malignancy in the woman. Global, it has now surpassed lung cancer as the leading cause of global cancer incidence in 2020, with an estimated 2.3 million new cases, representing around 12% of all cancer cases. In India, the incidence has increased significantly, almost 50% in between 1965 to 2000. Estimated number of incident cases in India in 2016 is around 1,20,000, and almost 99% of the cases are were females, around 1 to 1.5% were male breast cancer, and the prevalent cases were around 5,26,000. As per the Globocon 2020, in India, breast cancer accounted almost 14% of all cancer cases and 10.5% of all deaths with a number of new cases in the world. I will be how to work up anyway. Whenever we get the CA breast cases, patient will be presented with a lump in the breast, a long-standing painless lump, and sometimes with axillary lymph nodes also. Sometimes induration of the skin, sometimes discharge from the breast, sometimes in rare cases supraocular lymph nodes also. So we have to work up with history, physical examination, imaging, bilateral mammogram, ultrasound is necessary, breast MRI, especially mammographically occult tumors, and to know the status of axillary and internal mammary lymph node status, and pathology review, and we have to get the ISC report, estrogen receptor, PR receptor, and HER2 status, and genetic counseling if at all any patient is having this hereditary breast cancer, triple negative breast cancer, because these patients are requires olaparib, and depending on the investigation, we have to stage the patients. Only node positive patient we have to search for any occult primary, and stage 1, 2, 3, 4, and for metastatic we have to start with chemotherapy, and for stage 1, 2, 3 we have to see for whether it is operable or inoperable disease, and operable disease madam will cover in the next talk. What is the role of medical oncologist? Being a medical oncologist, I will be seeing the patients for adjuvant treatment setting, neoadjuvant and palliative treatment setting. In all these clinical settings, we have chemotherapy, hormonal therapy, targeted therapy, immunotherapy, and supportive treatment. Coming to the adjuvant treatment, goals of adjuvant system therapy are: it prevents the recurrence of breast cancer by eradicating micrometastatic deposits. Rationale for adjuvant treatment stems from the systemic hypothesis of breast tumorigenesis, which argues that in the early stages of breast cancer development, tumor cells are disseminated throughout the body. Adjuvant therapy helps to reduce the breast cancer death. It almost reduces 21% between 1975 to 2000. 7 independent meta-analyses showed median decline in mortality by 30%, due to improvement in screening procedure around 15%, due to adjuvant therapy around 20%. Adjuvant treatment modalities are mainly chemotherapy, endocrine treatment such as tamoxifen, aromatase inhibitors, or ovarian suppressor, anti-HER2 therapies like trastuzumab, pertuzumab, TDM, immune checkpoint inhibitors like pembrolizumab, PARP inhibitors like olaparib. Most commonly used and standard guidelines 4AC followed by 4-taxane is the taxanes is the main standard of care of any adjuvant patients in the breast cancer. And previously 6 CMF were the 1970, 80, and 90. CMF was the most commonly used regimen, and later 6 CMFs are equivalent to 4AC. And which anthracyclines are better? Pyriproxine and adriamycin almost equal rates, and toxicity profile is a little bit better with pyriproxine. Cost is more, and there are no independent direct comparative trials. And taxanes, these are the backbone of adjuvant or neoadjuvant or palliative setting. Absolute improvement is 5% for 5-year DFS and 2% 5-year OS. And most commonly used nowadays weekly paclitaxel for 12 cycles follow or every 3 weeks of docetaxel schedule resulted in an improvement in the outcomes compared to 3 weekly paclitaxel. Dose density, especially in TNBC, triple negative breast cancer patients, 4 cycles of AC every 2 weekly, followed by 4 cycles of paclitaxel every 2 weekly. Decrease the recurrence and improve survival. We have to support with growth factor support from day 3 to day 3. Trastuzumab, there are various trials which have shown very good benefit in the form of survival and DFS. All the trials have shown 1 year of Herceptin is better than 24 months or as compared to observation. And absolute benefit is more common with ER negative and PR negative patients and node positive patients. Timing of adjuvant therapy, relapse-free survival and overall survival were similar for women who started chemotherapy as long as 12 weeks after surgery. However, delays beyond 12 weeks resulted in compromised relapse-free survival and statistically inferior overall survival. This Kaplan-Meier curve shows whenever you start chemotherapy as early as possible, like usually you start up to 3 weeks of surgery. And whenever you start early, patient will be having better survival as compared to late starting, like more than 12 weeks or 24 weeks. Timing of endocrine treatment, inferior outcome with both chemotherapy and tamoxifen are administered simultaneously. So ideal to delay endocrine treatment until completion of chemotherapy. Duration of endocrine treatment, if patient is premenopausal woman, we have to continue for 10 years. And postmenopausal for low risk, it is 5 years. Low risk means negative or T1, T2 lesion. And for high risk, it is 10 years, more positive T3 or T4 lesions. And depending on the histopathology report or post-op report, we'll be dividing into 4 groups of breast cancer patients. One is hormone positive and HER2 positive patients. We will call it as triple positive breast cancer also. These are the high risk patients because of HER2 positive. And we have to start chemotherapy. Patient is size of the tumor is more than 0.5 centimeter or more positive or N1 micro. In N0, role of trastuzumab is very minimal. That is why NCCN recommends it is category 2 indication. And second category is hormone positive and HER2 negative. In the hormone positive, if patient is postmenopausal and node positive, patients can skip the chemotherapy if patient is having very good profile. That is by either Oncotype DX or Prosigna breast cancer index. Usually Oncotype DX is the standard and breast cancer index is the Indian version. But it is too costly, cost around 3 to 4 lakhs around for Oncotype DX. So if any patient is affordable, we will subject the patient to Oncotype DX. If recurrence score is less than 26, we will consider only endocrine therapy and we will skip the chemotherapy. If score is more than 26, then we will consider adjuvant chemotherapy and endocrine therapy. And any N2, N3 disease, we have to go with chemotherapy and endocrine therapy. Hormone positive and HER2 negative, if patient is premenopausal.
Irappai, can you be a little louder or near to the mic?
Yeah, sorry. And in premenopausal also we can consider, we can skip chemotherapy in some patients depending on the Oncotype DX score. If recurrence risk score is less than 15, we can skip with we can go ahead with only endocrine therapy or ovarian plus ovarian suppression. If recurrence is 16 to 25, endocrine therapy plus ovarian suppression or adjuvant chemotherapy. If score is more than 26, adjuvant chemotherapy and endocrine therapy both are needed. In premenopausal node positive, then again we have to go with both chemo and endocrine therapy. Yeah. Other than Oncotype DX, we are having 70 gene namaprint and 50 gene Prosigna and 12 gene endopredict and breast cancer index. Even ESMO guidelines mentions luminal A, luminal B, HER2 oversuppression and BSLI. In luminal A, these are very subset of patients. Strong ER positive, strong ER positive, PR positive, and HER2 negative Ki67 is very low and low risk of recurrence, like low risk molecular signatures. So we'll go ahead with endocrine. You can go ahead with endocrine therapy only. Whereas in luminal B, there are 2 subgroups: HER2 negative or HER2 positive. In HER2 negative, endocrine therapy and chemotherapy. HER2 positive, along with chemo and endocrine therapy, or to add anti-HER2 therapies. In HER2 positive, chemotherapy and N2L2, and triple negative, only chemotherapy is. In the hormone negative and HER2 positive, if any post-operative reports shows N1 micro or more than 0.5 centimeter, we have to consider adjuvant chemotherapy along with trastuzumab. If it is more than 1 centimeter, it is category 1 indication, chemotherapy and trastuzumab. And another subset, hormone negative and HER2 negative, we call it as triple negative breast cancer. This is very high risk. These patients are having very high risk of recurrence, and even genetically hereditary breast cancer risk is also there. So if any patient comes with N0, even N0 disease also, N0, N1 micro, you can consider adjuvant chemotherapy. And more than 0.5 centimeter, you have to consider for adjuvant chemotherapy. And some set of favorable histology patients like pure tubular, pure miscellaneous, pure cribriform, or encapsulated or solid papillary carcinoma. In that, if patient is more than 3 centimeter, you can less than up to 3 centimeter, you can avoid chemotherapy. Coming to adjuvant hormonal therapy, as previously discussed, if patient is premenopausal at diagnosis, you can start with tamoxifen for 5 years, plus or minus ovarian suppression. If patient becomes postmenopausal, we can continue with aromatase inhibitor for another 5 years to complete 10 years of hormone therapy. If a patient still is in premenopausal stage, we can continue with tamoxifen. If patient is postmenopausal at diagnosis, you can continue with aromatase inhibitor for 5 to 10 years, depending on the risk of recurrence. Definition than 60 years, or if age is less than 60 years and amenorrheic for 12 or more months in the absence of chemotherapy, tamoxifen, chloromepene, or ovarian suppression, and FSH and estradiol levels should be in the postmenopausal range. And if patient is taking tamoxifen or chloromepene and less than 60 years, FSH and estradiol levels should be in the postmenopausal range. Adjuvant radiotherapy, any patient with T3 lesion that is more than 5 centimeter, node positive, and margin positive. If tell margin positive, we can consider for re-excision also. Still, it is not possible, then we can consider for radiation. Even with the T2 lesions, like early lesions, tumors with more than 2 centimeter and at least one of the like grade 3 ER negative or LVA, these patients can also be considered for radiation. And all breast conservative surgery patients should be subjected for whole breast grafting along with nodal irradiation. Next, coming to neoadjuvant treatment. Principles of neoadjuvant treatment are randomized trials demonstrate similar long-term outcomes when patients are given the same treatment preoperatively compared with postoperatively. Pathology complete response to preoperative systemic therapy is associated with an extremely favorable disease-free survival and overall survival, especially in situation with patients were given all neoadjuvant therapy preoperative. Correlation between pathologic response and long-term outcome is strongest for triple negative breast cancer and HER2 positive disease, and least for hormone positive disease. All the chemotherapy drugs which are being used in adjuvant chemotherapy can be used as neoadjuvant chemotherapy. Endocrine therapy alone may be considered for patients with hormone receptor positive, especially more than 60 or 70 years elderly patients. And patients with HER2 positive tumors should be treated with preoperative systemic therapy along with like trastuzumab along minimum of 9 weeks of therapy. And pertuzumab containing therapies, if patient is having T2 or more, N1 lesions, we have to consider in the HER2 positive patients, pertuzumab can also be considered. When electing preoperative therapy, all treatment should be given prior to surgery. Tumor response should be routinely assessed by clinical examination during delivery of preoperative therapy. Patients with operable breast cancer experiencing progression of disease during preoperative systemic therapy should be taken for surgery or neoadjuvant radiation. Candidates for neoadjuvant are patients with inoperable breast cancer like inflammatory breast cancer, bulky or matted into the nodes, N3 disease, T4 tumors. Patients with operable disease, large primary tumor related to the breast size in a patient who desires breast conservation. Non-candidates for NECT are patients with extensive in situ disease when extent of invasive carcinoma is not well defined, Patients with poorly delineated extent of tumor preoperatively. Patients whose tumors are not palpable or clinically accessible. Known benefits of NACTR: it facilitates breast conservation, render inoperable tumors to operable disease, provides important prognostic information at an individual patient level based on response to therapy, especially in patients with triple negative and HER2 positive disease, allows time for genetic testing, and to plan breast reconstruction in patients who electing for mastectomy. These are the workup and surgical management actually discussed by Poovanna Madam. And post neoadjuvant therapy patient again we will divide into 4 groups. Hormone receptor positive and HER2 negative, we have to consider with continue with endocrine therapy. And if we are a patient is BRCA1 or 2 positive patients, then adjuvant olaparib can be considered. And hormone negative and HER2 positive, we have to continue with if pathological response is not there, then we can add TDM1 for 14 cycles. If patient is triple positive, we have to continue endocrine therapy and HER2 targeted therapies. And triple negative, if patient is not having pathological complete response, then we can add adjuvant capacitor for 6 to 8 cycles. If BRCA1 and 2 negative, olaparib for 1 year. And even nivolumab, this immunotherapy drugs can be used like pembrolizumab up to 14 cycles. These are the some of the neoadjuvant trials like NSABP B18 and B27 trial. In NSABP B18, 4AC surgery followed by 4AC versus surgery 4AC as neoadjuvant followed by operation. Both have equal rates, and one complete response and pathological response were seen. And node positivity is also very less as compared to direct surgery, and it is significant. And rate of lumpectomy is also more in the neoadjuvant group. Ipsilateral breast cancer recurrences are almost similar, and p-value is non-significant. Survival is also same. This is NSABP B27 here AC versus AC and docetaxel as neoadjuvant. Pathological complete PCR, pathological complete response rate with NACT for 4AC PCR is 8%, 4AC followed by 4 taxane PCR is 16%, taxane plus trastuzumab after AC is around 40%, 3 FEC followed by taxane plus trastuzumab and pertuzumab. In ER negative tumors, around up to 80% patients will be having pathological complete response, and in ER positive patients, around 45 to 50%. Neoadjuvant endocrine therapy for breast conservative therapy, around 30 to 40% of those who receive 4 months of endocrine therapy were eligible to go for breast conservative therapy. PCR rate is very less, it is around 3%, reserved for women who are not candidates for chemotherapy. Neoadjuvant endocrine therapy, most commonly used drugs are tamoxifen and letrozole. These are the pre-operative or adjuvant therapy regimens. Almost all the regimens are same, whether it will be NACT or adjuvant. Preferred regimens are dose dense AC, usually triple negative in the triple negative breast cancer. Adriamycin is 60 mg per meter square, cyclophosphamide 600 mg per meter square. Followed or preceded by paclitaxel airway PHC. Paclitaxel will be 175 mg per meter square for 4 cycles, or dose dense followed by weekly paclitaxel. And other regimens are docetaxel and cyclophosphamide, olaparib, BRCA1 and 2 are positive, high-risk TNBC, preoperative pembrolizumab, that is immunotherapy, and along with carboplatin and paclitaxel can be used. And in the adjuvant setting, we have to continue with pembrolizumab along with capacitor. Other regimens are CMF, capacitor maintenance if patient is having not having pathological complete response in TNBC. Other regimens in HER2 positive patients, paclitaxel, trastuzumab, TCH, which is less cardiotoxic as compared to AC followed by taxane along with Herceptin, and TCHP, docetaxel, carboplatin, trastuzumab, and pertuzumab. And follow-up of the patients after the completion of treatment, we have to ask the patient to come for follow-up once in 3 months, and genetic screening should be done. Those who are triple negative or any ovarian cancer or bilateral breast cancer patients, and imaging every 12 monthly yearly mammography, and we have to ask for lifestyle modifications, and patients on tamoxifen will be having some endometrial hyperplasia and all, cataract may be there. In the palliative treatment, systemic treatment for hormone positive and HER2 negative, we have to consider for if patient is premenopausal, ovarian ablation or suppression can be considered along with endocrine therapy. If patient is postmenopausal, we can use estrogen receptor modulators or aromatase inhibitors or CDK4/6 inhibitors like palbociclib or ribociclib along with aromatase inhibitors. These are the hormonal therapy regimens. Preferred regimens are first line aromatase inhibitors plus CDK4/6 inhibitors or palazestrant CDK4/6 inhibitor. Second line palazestrant CDK4/6 inhibitor. HER2 positive patients, pertuzumab, trastuzumab, docetaxel, TDM1, capacity.
Sir.
Hello.
Hello.
Dr.
Yes,
Irappa, I think the time allotted, I think you already crossed. Anyway, thank you for the detailed
Yes, ma'am.
presentation.
Over.
We'll be happy to listen to any queries and doubts. Now, I think we should request Dr. Povama to go
Yes,
ahead with
ma'am.
that
Thank you.
presentation.
Yes, ma'am. Thank you.
Dr. Moksha, can you start?
Yes, ma'am.
Okay.
One minute.
Can you start your slideshow?
Yes, yes, ma'am. 1 minute. Yeah. Good evening, all. It's a pleasure to be on this forum to talk about breast cancer. So I will be talking about screening and surgical management of breast cancer. So I think Dr. Irappa and a lot of the other speakers have already commented on why breast cancer is an important topic for discussion, especially in a health forum, because it's become the most common cancer worldwide among both the sexes, and it's also the most common cancer in females, overtaken cervical cancer as the most common cancer. And this holds true in India too. Breast cancer has overtaken cervical cancer, and it is said that 1 in every 21 women will develop breast cancer in India. The key question is, at what age should we start screening for breast cancer in India? We always consider data from the West and think that screening for breast cancer should start after the age of 50. But if we look at ICMR's data, and this is very important data, we know that in India, breast cancer occurs a decade earlier compared to the Western population. And if you go according to age-wise data for India, according to ICMR, nearly 4% of breast cancers occur in the age group of 20 to 30, and about 16% in the 30 to 40, and about 24% in the 40 to 50. So nearly about half of breast cancer in India is occurring in the age group of less than 50. So what we would say is every woman should be taught self-breast examination, especially to the primary contact point, which is most often the gynecologist or the general surgeon. I would say we have to teach women to be to be aware about their breasts and continue to propagate self-breast examination. And I think the most important message which needs to get out to the public is that breast cancer can be a very, very silent problem, because most assume that, breast cancer should come loudly with a lot of pain and other symptoms, but most often it's just a painless lump in the breast, which is the clinical complaint and often ignored because it's completely painless. So why do we have to screen for breast cancer? We know, as all doctors, we know that, breast cancer is one of the few cancers which can be detected early with regular routine screening. And with routine screening, the chances of picking up a cancer is very, very high, especially stage 1 breast cancers. The mortality of breast cancer in India is very high. It is said that for every 2 women diagnosed with breast cancer, 1 of them die in India, though we have the same state-of-the-art treatment available in India as compared to the West. And this is principally because of the late diagnosis of breast cancer. So stage 1 breast cancers have a cure rate as high as 96 to 98%, which we all know then dramatically decreases to less than 25% when it's stage 4. So with routine screening, the size of the tumor detected dramatically falls down, and a lot more would be screen detected early breast cancers. So what we would recommend is that all women, any women, whatever age, should be breast aware and have regular self-breast examinations. Any women coming with a complaint of a lump in the breast should be evaluated clinically and should ideally undergo an ultrasound, and depending on the ultrasound findings, if it's suspicious, consider a mammogram and consider a biopsy. All women above 40 years of age, clinical breast examination with mammogram once in a year or at least once in every 2 years. And I think the rates of screening in India is drastically low, and most come with complaints of a tumor, and usually it's stage 2 or most often stage 3 and stage 4. Why do we talk about digital mammograms and tomosynthesis actually? So a tomosynthesis is a 3D mammogram. And this is especially important for our population because many of our women tend to be very, very young, and younger women tend to have very dense breasts on which, because of which tumor detection rate goes down. So this is just a picture showing you a 2D image in which the cancer is not easily picked up. But when you see a 3D image and you go from image to image, you can see that a very small tumor is visible and it was identified. And this was a screen detected lesion who underwent a tomosynthesis for breast cancer. Obviously, we know what are the things we can do to reduce the risk, and I think again obesity is on the rise, and we as doctors, it's our primary. We should give this knowledge out how we can reduce the risk for breast cancer. So breast cancer treatment has undergone a dramatic shift from the years before, and we know that breast cancer is a systemic disease from start. We have moved away from radical mastectomies to conservation and now to oncoplastic breast surgery. The treatment is tailorized to the individual person. Dr. Irappa has already discussed about what are the indications for adjuvant and neoadjuvant chemo and when we plan surgery. So some of the old factors remain true. Any tumors more than 5 centimeters, tumor to breast ratio is very high. Evidence of skin involvement, edema, all of these patients have to go for neoadjuvant chemotherapy. One of the other things is with oncoplastic breast surgery, what we can do is especially if the tumor breast ratio is very low, we can start them off on NACT and they become candidates for breast conservation. But what is important is before we start NACT, we usually place in a marker pin at the tumor bed into the tumor so that we would be able to identify these tumor pins a little later. Which will increase so that we can conserve the breast safely and only remove the tumor bed and not remove the entire breast. So today we are in the era of oncoplastic breast surgery, which increases the aesthetic outcomes, better tumor margins, a high patient satisfaction, especially compared when we take into the focus that many of our patients are very young, and obviously with good treatment, their long-term outcomes are very good. So we have to consider their how are they going to be after the treatment. We cannot advocate only mastectomies to these women. The oncoplastic breast surgery, the way we do it has moved. There are a lot of different techniques which we can do, from simple wide local excision and glandular mobilization to extensive volume displacement techniques, and also to volume replacement techniques with a lot of local flaps like LD flap, LECAP flaps. a pedicle tram, and we also offer free flaps with microvascular. Most commonly used flap is the DIEP flap. We also offer symmetrizing procedures for women on the contralateral breast, and the choice of this oncoplastic surgery will depend on the size and location of the tumor, the volume of the tumor, and the consistency of the breast. So these are different pictures of women who've undergone breast surgery for cancer, and you can see with different types of oncoplastic techniques which have been used, we can give them very good aesthetic outcomes. And I think many a times we as doctors, when it comes to our own family and friends, we always say mastectomy, but we don't see what is the future for these women, how it affects their family life, how it affects their confidence. And we have enough evidence from the NSAB trials to say that a breast conservation with radiation is equivalent to a mastectomy, and the chances of recurrence are very low. But patient selection is very important for women with extensive DCIS, skin involvement. I would suggest that, still stick to mastectomy, or with people with multicentric tumors, still stick to mastectomy and offer them a reconstruction as and when required. A lot of the local flaps which we can use, also the intercostal based flaps, which we take from the lateral chest wall, so the patient doesn't really have much morbidity because of that. And these are post-op images of women who've undergone resection of tumors with a volume displacement from the lateral chest wall into the breast, give them a very good aesthetic outcome. Again, another different types of volume displacement techniques which we use to give very good aesthetic outcomes to women. The other, one of the other techniques which we use commonly is the breast reduction techniques, which the plastic surgeons use, where we use that technique especially to reduce to remove big tumors with very good margin status, and at the same time we reduce the opposite breast to match the side of the tumor. And you can see we can get excellent outcomes. Women are very happy. They go back, and after the completion of treatment, remnants of the surgical remnant is not that they're flat chested, and they go back with confidence to their regular life. Again, another patient with similar techniques of breast reduction used. One of the other options we can also give for patients who have to undergo a mastectomy, usually the reason for a mastectomy would be extensive DCIS or multicentric tumors. We can offer them directly mastectomy to implant also, so that they go back okay. And this is another option which we have for these patients. For women who have bigger tumors, where maybe they have to be exposed to radiation, especially tumors more than 5 centimeters, then directly mastectomy to implant may not be an option of choice, because radiation can cause problems with the implant in situ and cause increased risk for capsular contracture and extrusion of the implant. And here what we choose to do is put in an expander for the duration of the radiation, and then slowly expand it post radiation and keep it expanded for some time, and maybe 6 to 8 months later we do an exchange surgery or where we remove the expander and put in an implant for these women. These are also okay of patients who have been reconstructed when the volume of resection is much higher and we cannot use small displacement techniques. We also use replacement techniques where we take the LD flap and use that to reconstruct nearly half the breast, and we can match the opposite side really well. Again, this is sometimes an option where this LD plus implant can be used. The last option is also the free flaps, which are routinely used for breast reconstructions. The plus point is they get a tummy tuck along with the breast reconstruction. Most commonly used flap is the DIEP flap, which is based on the abdomen. And the second most often used flap is ALT, but most often we use DIP. The only thing is we do need a plastic team for this, because the surgical time definitely goes up by at least 4 to 6 hours. But women are very satisfied, and they go back with a normal feeling breast and a reduced tummy. This is again when we show where we can, aesthetically offer them a contralateral symmetrization procedure to match the breast. The other thing we can also offer our women is delayed reconstruction. Sometimes women are overwhelmed at the time of diagnosis of breast cancer and are unable to make decisions, and then they say, okay, let me have a mastectomy, or whatever the reason for mastectomy may be, the reason be, they can come back years later and say, I want a reconstruction, and we can offer them a delayed reconstruction too. From the axillary point of view, now we've moved away from complete axillary dissection, especially when it looks, nodes look normal. We have moved to an era of sentinel lymph node biopsy for node negative patients. Also, we're considering sentinel lymph node biopsy for women post NACT, even if they were node positive. After the NACT, we do radiological examinations to see how the tumors are, and if the nodes are completely looking normal, we can do sentinel lymph node biopsy, but at least remove 5 lymph nodes and subject it to frozen section. And if anything is suspicious or positive, please remove them. We also move to an era where we're using clipping of the suspected nodes before neoadjuvant chemotherapy and doing targeted axillary dissection instead of doing a complete axillary dissection. Either we can do charcoal tattooing of the suspicious node, or we can also put in a clip into the node which can be detected post NACT, and we remove only the suspicious nodes. This Dr. Irappa has already spoken about. So what I want to say is, we have in breast cancer, the role of surgery is still very much there. We can also use neoadjuvant chemotherapy as a surgical tool to decrease the size of the tumor and then to conserve the breast aesthetically. For many of the triple negative breast cancers and the HER2 new positive breast cancers, we start with neoadjuvant chemotherapy. Please remember to put in a clip into the tumor area so that we can save the breast later on and send these women back home with the aesthetically preserved breast. I think Dr. Irappa has already covered extensively from the medical point of view, including chemotherapy and hormone therapy. And this is what is the latest for breast cancer from the surgical point of view.
Very nice presentation, Dr. Poma. It was, I think, made very simple and very straightforward and very clear. With the both presentations, it looks like the aggressive Halstedian procedures, what we would do earlier conduct, really are not required. And with the combined chemotherapy and also the radiotherapy, plus the appropriate personalized surgical treatment for the CA breast, I think majority of the patients definitely do well. But as a role, as our role as general surgeons, general physicians, I think is to ensure that we really teach the patients proper breast examination, encourage them to undergo regular checkup in the form of both ultrasound or it could be mammogram, and ensure that we are able to pick them up much early. I'll be happy to receive any questions and direct to the concerned specialist here. Dr. Pawan, you have something to tell?
Hello.
Nothing, madam.
Yeah.
It is always a pleasure to listen to Puama because she was my colleague at the college.
Yes.
Thank you, madam.
Shivanand sir, you have any specific questions? Dr. Salim, Dr. Rajeshri, I think both of them will be definitely happy to respond to us.
Madam, good evening.
Good evening.
It was nice presentation, madam. Actually, I joined very late. The surgical presentation only I joined. It was very nice one. As Dr. Suresh Kagalkar had one question, I think.
Yes,
is there a tumor marker for breast? Can this be answered?
Can any one of you answer regarding any specific tumor markers which are known?
Because why, madam? We are doing routinely the PR examination for the cancer as well as doing the serum PSA. So doing this minimal investigation, you can able to detect many of the malignancies early. Like that, early detection apart from the mammography. So So as a physician in the periphery area,
I think the genetic markers are already present. Can one of you highlight Dr. Poma or Dr. Madhavi?
Good evening, ma'am. Ma'am, actually, we used to do CA 15.3 for breast cancer, but it is non-specific actually, like CA 125. These are only like if lump is there, that is there, then we'll confirm it. We can do in the blood CA 15.3, we can consider.
Okay, sir.
Yes, ma'am.
But I think we are still not used to using them extensively in trying to look for them.
Because ma'am, most of the patients like screening we used to do, but most of the patients here in India, almost everywhere, most of the times patients will come in the second stage or third stage. That in that stage we usually do.
Yeah, and even Matt, I would say CA 15.3 is not very specific. It doesn't necessarily have to be elevated in breast cancers. So just using that as a screening tool may not be adequate at all.
So still, I think the standard self-examination of the breast and triple assessment still holds good.
Still holds good, yes. The old is still gold standard, I would say.
Okay.
The only thing we could talk about is for genetic treatment when there's a question there. Genetic examination, when there's very, very strong family history, has become very accessible to people today. I would say even 10 years back, considering doing a BRCA1 or BRCA2 testing used to be ridiculously expensive, costing 75,000 to a lakh. And today, within about 10,000, we can get BRCA1 and BRCA2. And we're starting to get our own data today. I think before we always relied on the Western data. And now when that we are using this routinely, we're seeing quite a bit of pockets of BRCA1 and BRCA2 positivity in India. So I think so that is one thing, especially with very strong family history, we can start using that test more often so that at least all the other family members can be evaluated and we can do risk reducing techniques, either risk reducing medication in the form of tamoxifen, raloxifene, or at least consider mastectomy with reconstruction, or at least strong surveillance for these individuals with a very strong family history.
Okay, that's really nice. I think already probably some centers like yours where you do have a direct access to these educated patients. Are you getting these patients voluntarily coming for some intervention, knowing very well that they have their own relatives?
Yes, ma'am. We're getting quite a bit of them who are BRCA positive and who are considering immediate, risk-reducing opposite mastectomy with a bilateral sulfingo-oophorectomy. But many of them tend to be very young too. That is another problem. But I would say the most important thing that we are seeing is we're seeing a lot of women in their 30s today. A lot of women 31, 32, and a lot of pregnancy-related breast cancers also. So before, the definition for pregnancy-related breast cancer was any tumor within 1 year post a pregnancy. But some of the newer definitions are up to 6 years post pregnancy, and the numbers in that age group is very high, and detection is very difficult because invariably it's thought that it's a galactosile or lactational changes, and most of these set of women come in stage 3, stage 4 because it's not been identified correctly by us doctors. So I think that's the only thing take back is to especially gynecologists have a high degree of suspicion. Post-pregnancy lumps, we shouldn't just, obviously there will be a small number, but have a high degree of suspicion.
Yeah, that is there. Including many of us, we tend to take it lightly. That's something which should not happen. Agreed, definitely. And I think even in our Karnataka, to my experience, the Hubli Cancer Hospital has some data of their own, BRCA1 and CA2. 20-30 families have been identified. That was what I was told. Yes. I hope so. Definitely some of them are getting back and trying to go in for the early intervention. But sadly, we are also seeing the non-high risk groups coming. That's one of them which we are unable to understand the reason. Yes. At the same time, the first pregnancy is getting postponed significantly.
Yes, I think that is the reason, because of the postponement of the first pregnancy. We always think pregnancy is a protective factor for breast cancer, but if you go down and look at the intrinsic data for breast cancer, it is said that pregnancy is protective after 10 years post a pregnancy, it's protective against breast cancer. For the first 10 years after a pregnancy, there's a slight increased risk for breast cancer. I think especially now because most women are elderly, you would say, elderly primigravida, are more than 30, 35. So I think because of that, we are seeing a higher incidence of women coming with breast cancers in the 30 to 40 age group.
Any questions? We'll be happy. I think both of them definitely will give us a very nice details. Anything else anybody wish to add, or there is a request from Dr. Maya, role of radiation.
Yes, I was just reading that. So role of radiation definitely plays a role in breast cancer. We would say that once you conserve the breast has to be irradiated to prevent a second new breast cancer from arising. And for mastectomy patients, any women with tumors more than 5 centimeters, nodal disease more than 2 or 3 positive lymph nodes, involvement of skin, even post mastectomy, they will have to receive radiation therapy.
I think even to my general understanding is the quality of the radiotherapy also has significantly increased with significant reduction in the morbidity and the apprehension what majority of us used to have regarding the local radiotherapy. Hardly any local complications.
Yes, we have hardly any local problems. Only women with extensive nodal involvement sometimes require radiation to supraclavicular fossa. So especially if it's on the left side, then for some time during radiation therapy, because of the involvement of esophagus during radiation, they may complain of difficulties in swallowing. But other than that, radiation is very well tolerated, and with the newer machines, we don't see any cardiac or lung toxicity at all. It's very, very minimal. And it's very safe, I would say.
And I think even because of the customized chemotherapy, we are seeing much less side effects or the poor outcomes due to chemotherapy. Dr. Irappa, I think probably, at least to my understanding, I may not be 100% right. Majority of our patients, as Dr. Poma was telling us, are in the 4th decade, late third decades, or maybe early 50s who come to us in 2nd stage or 3rd stage. Is it similar everywhere? And how do you tentative? I do agree you plan as per the staging and other things. Are there any other considerations also when you plan the chemotherapy?
Ma'am, sorry, ma'am, I did not get you properly, ma'am.
Okay, sorry. Basically, because majority, as what Dr. Poma was telling, we still see stage 2 and stage 3 patients. And majority are either perimenopausal or just completed or in the premenopausal stage. In addition to the exclusive scientific basis, clinical staging, do you have any other factors which you consider when you plan for chemotherapy?
Like, ma'am, any other comorbidities like diabetic patients, we usually avoid vaccines if node negative, ma'am. And any cardiac problems are there, anthracyclines we will avoid, ma'am, because of anthracyclines cause cardiotoxicity. And even diabetic patients, most of the times peripheral neuropathy will be there, ma'am. So in that case, we used to avoid paclitaxel because it is having more common peripheral neuropathy as compared to docetaxel. In younger patient, ma'am, we used to give AC followed by taxane because these patients are more prone for recurrence because of early breast cancer, even in the younger age, more aggressive disease. Most of the times, triple negative or HER2 positive disease. These patients need more follow-up and we have to give adequate treatment. In the elderly, we used to like plus minus, we will avoid, sometimes we will avoid anthracyclines if patient is having cardiotoxicity. Already any cardiac problems are there, definitely we have to avoid. And if patient is affordable, to targeted like TCH, we used to do frequently here. That contains docetaxel, carboplatin, and trastuzumab. And less as compared to anthracyclines, they are less cardiotoxicity as compared to anthracyclines followed by taxane plus trastuzumab. And as compared to Western Indians, like early presentation is more common and late presentation is there. And most of them usually we get stage 3, most commonly stage 3 followed by stage 2. And stage 3 and 4 almost 30-35% we used to get all the breast cancer patients in the stage 3 and 4. Yeah.
luckily the chemotherapy drugs cost also has reasonably come down, and that has greatly added for the options, I believe. Otherwise, especially non-insured patients or with limited resources, first consideration would be the cost, and then second thing would be the other things. Hopefully those things are much less now.
Yes, ma'am. Here, like in last 7 years, almost 90% we are giving treatment under AP, this one, Ayushman Bharat only.
Yeah, that
BPL
is
card
something
only.
very good. Yes.
Yeah, ma'am. Except trastuzumab, we are giving almost all chemotherapy, radiation, surgery, everything will be covered in schemes of them. And here, most of the times, 90% will come with BPL card only. If BPL card is there, then only they will come here. Otherwise, they will go somewhere else.
I think one more thing just to add, I think especially for younger women now, if they've not completed their families or still have to plan, we also would consider ovarian suppression at the time of chemotherapy just to keep the ovaries protected, and also counsel for fertility preservation or embryo preservation, ovarian tissue preservation for these younger set.
I think even psychological counseling is also very important once the diagnosis are the survivors, very much, because even the family has to take up the issue, the patient being like, having breast cancer. So a lot of psychological counseling plays a major role.
There was another question whether stage 3, who do we refer to? So the answer to that would be stage 3 is still a curable breast cancer. Only stage 4, we would say we'll just control it. So stage 3 typically will still undergo surgery, chemotherapy, radiation therapy, and the entire gamut of treatment, I would say. So it's still curable. Stage 3 is still curable.
Definitely. I think that CA breast per se is a disease where all of them are required at all the stages.
Yes.
Except I think even in stage 4 also, unless the tumor is too small and really needs only palliation and chemotherapy, even a simple reduction in this amount of the tumor also definitely helps the other specialists in reducing the overall dosage and the quantity, and the outcomes definitely are compared to any good centers. That's something what we have noted is our Indian counterparts, the survival rates are definitely as good as what we read in the
Western population.
Yes, definitely. Dr. Suresh, do we have some time or?
Hello.
How much is the time?
Yeah. Thank you, madam. Thank you, Puma,
anything,
madam,
any specific recommendations from both of you? Dr. Puma and Dr. Irappa, for all of us.
I would just say have a high degree of suspicion, especially in the younger lot. And fibroadenomas clinically can resemble a triple negative breast cancer. They're typically nice, smooth, well mobile lumps, which we kind of think it's a fibroadenoma on clinical examination. But at least on ultrasound, we would be able to make out microlobulations and diagnose it. So only that, just because clinically it looks like a nice smooth lump, that could be a triple negative breast cancer. So just have a high degree of suspicion, because younger women tend to have more aggressive breast cancers, and we can't afford to miss it and diagnose them later in stage 3 and stage 4.
Director Irappa, you would like to add something?
Yes.
Yeah. Okay, then Dr. Suresh, should we wind up? I think we really had a very good broad coverage of both from both the specialists, and the take-home lesson is pick them up early, do the needful, and see that they do very well later on with good survival. Dr. Veena, madam, you have anything to add?
So, madam, as a screening test, like we have to educate the woman for breast examination, and for small, as madam said, if it is fibroadenoma also, the chances of malignancy is high. So when the patient comes, I have a lump. So usually we'll examine and we'll tell, no, don't worry, don't get scared, and we'll be telling. But then we will be referring them for biopsy and so on. But that we have to make the people that it is not a cancer, it is a breast disease. So there is a total cure is there, because when, as Padma madam said, when breast cancer is diagnosed, whatever, if the government, Ayushman, everything is there, whole the life, whatever that flow was there, it will become a stuck, like they have to go for
majority of them
investigations.
are in their active life.
Yeah, treatment and chemotherapy, radiotherapy, and for that money management, whatever, travel, everything. Because I suffered because my mother had the CA breast, and how the scenario changed in my house, and I have to come to. I left my job and I came to Sulya for that purpose only. So I know what is the stress that people will undergo. So that part, counseling, we have to counsel not only the patient, whole family we have to counsel. And if still, if it is like beyond our hands, and if the disease is getting progressed and metastasis, all those things, it's really horrible. As a doctor, we'll be telling we have so much cure rate, mortality is less, morbidity is less. But when you take single patient and single family, I've seen many people suffering a lot. Let us hope that all women, whoever has a breast cancer, let it be diagnosed very early, as early as possible, and get cured. Let not get metastasis, and let them have a normal life. And Dr. Puama, as she said, and they were trying to give as that look like that plastic surgery and transplants, all those things, give them a boost to involve in the society, because everybody will be telling, and we have seen with mastectomy and lymph node resection, that whole limb getting swollen, and like everybody will be asking, no, what happened, and all. All those things have been come down actually, because I'm seeing since 20-25 years with the breast cancer, people are moving okay with the society. Yeah, let us hope that all of them will not suffer. Let them get diagnosed early, and we should be doing as much as screening possible, and giving the health education to them to come early also, because breast means they will be coming little late also. One side they will come early, in another side, like they will be thinking, let us see, like they will be postponing and taking some other medicines and all. So that health awareness, health education is very important, I think. Thank you, for Dr. Puama and Dr. Professor.
Kumsan sir, you have anything to add? We have all nice senior people here who have had, I think, significant experience. And as what Dr. Veena told, apart from the scientific approach, the psychosocial, financial approach, a holistic approach is essential when it comes to managing these patients. It's managing the lady, it's managing the family and everything. And Dr. Suresh, if we do not have any questions, can we wind up, or there is anything else anybody wishes to add?
Yeah, Lakol sir. Sir, are you here, sir? Dr. Lakol sir. Shivakumar Lakol sir.
Illa, avaru illa. Illa, sir.
Karunakar sir. Karunakar sir.
Yaru illa.
Okay, now, thank you. Now we have a vote of thanks. First of all, for success of this program is mainly because of the speaker. One is Dr. Puama. She is a friend of Dr. Tejaswini Madam. The conversation and many questions and a lot of discussion happened, and it was really enlightening, and many of the family physicians came to know a lot of things. And thank you, Dr. Puama Madam, for giving a wonderful lesson. And also I thanked Dr. Hello.
Yeah.
Yerappa Madhavi sir, who is from Bagalkot, and he's working in the Kerudu Cancer Hospital. So sir is a famous oncologist, and we are referring the patient from the North Karnataka to the Bagalkot Kerudu Cancer Hospital. And it was a wonderful lecture. Many of the things we came to know as a family physician. And thank you, sir, for enlightening many of the different knowledge about the CA breast. Thank you very much, sir. And also I thank to the chairperson, Dr. who is a surgeon and a professor of the BLE Medical College Department of Surgery, for chairing the session.
Thank you, everyone, for this opportunity to be with you.
Thank you, madam. And IMA KSP is always welcome to the different platform in the future also, madam. So we want your experience and your
Definitely.
association with us, KSP,
Sure.
madam. Thank you, and also thank you to the IMA KSB, our president, Dr. Shivkumar Lakkol, sir, and also I thanks to our secretary, Dr. Karunakar, sir, who has given a prayer of IMA. That is also important, and all the programs it is a mandatory, madam. And also thanks to the Dr. Veena N, madam, Dr. Padma Prakash, madam, and important Dr. Shivanand Kumsa, sir, who has joined and have given many important hints about the program, and also encouraged about the program. And also I
Right, sir.
Okay, thank you, everyone.
Thank you, everyone.
IMA
Thank
KSB.
you. Good night.
Thank you, madam.
Thank you.
And thank you everyone for attending the program. We'll see in the next everyone, and thank you and all. Thank you.
Thank you.
We'll wind up, madam. Thank you.
Okay.
Thank you.
Thank you.
Thank you,
everyone.
and good night, everyone.
Good night.